Well, it's a real honor to be here today to speak to many of you, faces who are familiar, friends, and others who I look forward to getting to know, and in particular to provide some background to the amazing work that's being done by Blythe with Courageous Parents Network. Someone said to me just as we were chatting, why is it so hard to talk about children's palliative care? And, you know, I ask you to reflect on that as we sit together, because this is an area in deep need of support, and yet how we get our message out there to not necessarily highlight the sadness and tragedy, but I hope also the beauty and importance of this this way of living when you have a child with a serious illness, and welcome your thoughts really on how we can mobilize the community to better support children's palliative care and other efforts. So I hope in this next 20 minutes or so to talk about what is palliative care, who are the children in need of palliative care, a moment about just reflecting together about suffering, what are effective strategies to easing suffering, and ask the question, has palliative care improved any outcomes? So in terms of what is palliative care, you may or may not be familiar with this diagram that we use in the field that shows the trajectory of what families experience in the care of a child with a serious illness. There's a very varying period of time, which can be very short or very, very long years, where there's often an individualized blending of care that's focused at the underlying illness and at the same time the well-being of the child and family, that is the physical, emotional, social, and spiritual needs of that child and family. And there's a continuous reevaluation and adjustment. So it's a very comprehensive and longitudinal approach to the care of these children and families. There's a period of time that I label the end-of-life care period, where perhaps care is almost entirely focused on the comfort of that child. But that period of time may only be moments or can be months, and also very variable. And even there are times, and I'll share some anecdotes with you in a little bit when I show you some of the children and families we serve, where you think you're at end of life and then you're not. And that sort of flexibility in adjusting how you approach living when you're in this existence of uncertainty, constant uncertainty, is how palliative care services try and hold families and provide a safety net in the context of that. Now, bereavement care starts well before a child dies. What we do during that period of time impacts greatly on the outcome of surviving family members, and not only surviving parents, but siblings, friends, and the community, because we know that there's an enormous ripple effect. One of the challenges, again, in palliative care for children is, fortunately, we're talking about relatively small numbers. But that impact is far greater on many, many more people. And so we need to understand that this is truly a societal issue and not just an isolated family issue. And what parents have told us is that in order that this care enables a continued hope when you have a child with a serious illness for the possibility of cure, and if not that, life extension, and even a miracle down to the very last breath. And at the same time, families hope for comfort and meaning. And it's not an either-or approach to care, and our work is around blending these goals of care. Of course, to do so, we need to think about all the elements of care that go into the possibility of creating meaningful experiences for the child and family. We know that this requires exquisite communication, intensive symptom management, a timeliness and a flexibility that allows this care to sort of live with the child and family wherever that child may reside, intensive psychosocial and spiritual support, care that's both child-oriented and family-oriented, and sometimes figuring out the best balance between the child and family is a very complex area of care. Any place, any time to create these meaningful experiences. And to do so, the foundation of palliative care is based on the interdisciplinary healthcare team in partnership with patient and families. And I think that what we'll hear about after I speak is the initiative from the family perspective based on Blythe's work. And these initiatives go hand in hand, and you'll hear more about that. From a healthcare perspective, there's physicians and nurse practitioners, chaplains, social workers, pharmacists, child life therapists, teachers, community providers, many, many others that provide this sort of safety net of care for these children and families. And a moment just to clarify the difference between hospice care and palliative care. Hospice care is a health care benefit. It's provided through hospice teams that are that receive support either from insurances or the government through Medicare or Medicaid to take care of patients almost entirely with a focus on comfort. Patients who are clearly at least delineated by their healthcare team as having 6 months to live or less. And that sort of program of care is often delivered in the home, can be delivered in a hospice house, and can also be delivered in nursing homes and in hospitals. But it's very, very specific. And sometimes kids with serious illness receive hospice care towards the end of life, but palliative care is a much more longer lasting approach to care, again with the focus on living life and living life well. So who are these children that we're serving in palliative care? They are hundreds of thousands of children within this country. An estimate might be 500,000 children at any one time are living with complex, chronic, serious illnesses. In light of all of this complexity, there's the experience of suffering. And so I wanted to share with you the words of Eric Cassell, who's written an extraordinary book, The Nature of Suffering. He's an internist who has sort of shared a lot of wisdom in the field of palliative care. He says, suffering is a specific state of distress that occurs when the intactness or the integrity of the person is threatened or disrupted. It lasts until the threat is gone or integrity is restored. The meanings and fear are personal and individual, so that even if two patients have the same symptoms, their suffering would be different. If I injured myself or broke my arm, and one of you in the audience broke your arm, our experience of pain would be vastly different. And what comes into play are all the factors that make up who I am as a person, not only the physiological fracture in my body. So we think of suffering based on these words, and we sort of have a framework for sort of understanding and then trying to ease suffering. And in pediatrics, we always think of it in the context of a family, not just the child. And then there's an illness. A child is diagnosed with a serious or life-threatening illness, and there are visible threats, the ones that we all can see, just like the diagnosis perhaps of cystic fibrosis leading to breathing difficulties, so physical symptoms, but then there are all these invisible threats. There's disruptions from normal life. There's emotional factors, existential concerns, sociodemographic factors. One of the talented young investigators that I have a chance to work with right now, Dr. Kira Bona, is looking at the impact of financial hardship, financial suffering on the outcomes of children with cancer. And one of the most poignant findings that she's discovered more recently is if you think of material hardship, that's food, housing, or energy insecurity. About 20% of families nationally or in the state of Massachusetts live with material hardship. And 20% of families who come into the cancer care arena have material hardship. So what would you imagine happens over the first 6 months of treatment? We have this intensive psychosocial support. We have these great resources available for families. Does that material hardship go up, stay the same, or go down? And sadly, what she's uncovered is at 6 months, 30% of our families experience material hardship. 1 in 3 families. And yet we have a robust program to try and support these families. So there's invisible issues that we need to uncover in order to mitigate that suffering. And we think of targeted interventions, like thinking of new ways to treat symptoms, and global interventions, broad interventions. And in palliative care, the procedure that we always start with is a goals of care discussion. Communication and the nuance of communication is so important in affecting change for these families, all with the goal of restoring family integrity. It may never be the same as it was before, but we want to restore that integrity. So one effective strategy for easing suffering is untangling the communication that is typical in our healthcare system. And I just wanted to offer you an example of what we do when we meet a family for the first time. We have 5 questions that we ask. It's a simple procedure, so to speak, that we offer other clinicians to use in their health care. The first question, if you think about your own interactions with clinicians, doctors, nurse practitioners, they'll often ask you, so what brought you here today? And it's not what kind of car, but what's going on with you physically. And often that's what's expected when you're meeting a new family for the first time. Well, our first question is, tell us about your child, or tell us about yourself as a person. What's your child like? What was your child like before he got sick? Or what does he enjoy? What makes him happy? And just starting a conversation with a different frame sets us up to have a different kind of relationship with these families. And the other questions are asking about the family understanding of the illness. In light of the understanding, this is where we get to goals of care. What's most important to you? What are your hopes and what are your worries? And finally, where do you find your strength? It really helps us to uncover for families whether or not there's a spiritual system that contributes to their strength. Most often they say, my child, my family, my community, yoga, meditation. What are those resources and how well are they working for you right now? That's all we do in our first meeting typically, just to set the stage for how we're going to best take care of these children and families. And that's a goals of care discussion. And then once we have that frame, we can figure out our approach to how to take care of that child. And this is just a schema that simplifies things. Often those goals sort of can be in 3 different buckets. Live as long as possible, live as long as possible and as well as possible, live as comfortably as possible. And it helps us to target our approach to assessment, treatment, and follow-up, all of which should be intensive but tailored to the goals of the child and family. I'll just close by sharing with you some data about whether or not palliative care has improved outcomes. This was a very well-publicized, outstanding study in the adult world looking at the care of adults with lung cancer and whether or not early access to palliative care resulted in any differences. And what's striking is that there was improved quality of life, decreased depression, and importantly, increased survival duration amongst patients with advanced lung cancers. Now you ask the question, how is that? But if you build resilience and strength and physical and emotional and spiritual well-being, you can imagine just logically why that would enable someone to live longer. In pediatrics, With palliative care, we haven't done a randomized control trial. Families report improved communication. Families experience shorter hospitalizations and fewer emergency department visits. Children experience less suffering from the perspective of their parents, and children are more likely to have fun. We still are a young field, and there's a lot of room for growth with regard to access to palliative care. We need a much more substantial workforce, both at the primary palliative care level, people who are taking care of patients who may not be subspecialists, and subspecialty training and research and innovation. As we think about this field, in the words of one parent, she says, another mother, the mother of Eric, comes up to them. It's all very hard, she says, her head cocked to one side, but there's a lot of collateral beauty along the way. Thank you.